Hello everyone and welcome to CK Med. My name is Clark and I'll be taking you through abdomen today. So before we start, what we're going to be touching upon is abdominal anatomy and clinical aspects of that anatomy that are going to help you for your step 1 as well as your anatomy exams. So to start things off, you need to understand what is the GI tract. The main thing that we're going to be focusing on in the abdomen is the GI tract. That's the main thing that's there. Later we'll be discussing other abdominal organs and other things found within this area, but our main focus again is going to be that GI tract. And out of your exam for this material, this is going to be the most high yield material is on what is happening in each of these areas of the GI tract. And so what the best part of this is that the GI tract is super organized. And so you shouldn't be able to really, you'd have a hard time actually, once you learn this, missing any questions that are involved around clinical vignettes for this section. And I'll definitely kind of point out, hey, don't forget this very particular details. They like asking this very particular location of certain things when we get there. So the organization of the GI tract is very great because it kind of goes back to embryological origin and then it takes everything with it and stays in the same orientation. So what this is kind of split down is your foregut, your midgut, and your hindgut. And so in embryological development, these are kind of the sections and areas that give rise to certain organs, certain nerves and blood supplies, and venous drainage from each of those areas. And so one thing you should remember when we're talking about certain areas is that everything kind of clumps together. And so when in doubt, try to keep it clumped together in your mind. So when we're talking about foregut, we're really talking about the lower portion of the esophagus, the stomach, the first part of the duodenum, the liver, gallbladder, pancreas, and then blood supply to the spleen. And these are kind of the organs and areas of our GI tract that are derived from our foregut. But please remember, spleen is actually not a foregut structure. Its blood supply is from foregut, but it is not a foregut structure, and it actually is derived from mesoderm, such as other structures that come from mesoderm, muscle, for example, muscle and bone. And so foregut actually gives rise to all the remaining structures, not the spleen, but it does give blood supply to the spleen. So just kind of lump that together. And pretty much as far as the tubes, it goes from esophagus to the first part of the duodenum. At the dividing point between the first and second part of the duodenum, you have this opening from the common biliary duct that dumps out bile into your duodenum. And this is known as the ampulla levator and the sphincter of Oddi. That is the opening there. And that is actually the dividing point of the foregut to midgut. Then we get down to midgut, and this is pretty much the distal, starting from the second part of the duodenum through the duodenum, ileum, cecum, which is the first part of the large intestines. Once past the ileum, the ileocecal valve, then it goes to the appendage, which is also right there, hanging out at the end of the colon, and then the ascending colon, and then the proximal 2/3 of the transverse colon. So you go up along the ascending colon, you go across 2/3 of the way and cut that off, and that is midgut. And then you finally switch over to the last part, which is the hindgut, which is the distal third, also called the splenic flexure of your large intestine. And then that goes down descending colon, sigmoid colon, and then the rectum. And you might be asking, what are these nerves innervating here? These are just kind of associated dermatomes when we're talking about referred pain. We'll be talking about that in a little bit. But the nerve supply to our foregut is T5 to T9. So if you think of, okay, where is T5 to T9? That is actually in your epigastric region. So when you have pain in your esophagus, such as GERD, for example, someone that has gastroesophageal reflux disease, they have heartburn. Where is that heartburn? That is in the upper abdomen, or even in the chest or lower chest behind the sternum. And so that's kind of someone that has esophageal pain. If they have ulcers in the stomach or the first part of the duodenum, they're also going to have that epigastric pain. Pancreatitis, where do we have that pain? Upper abdomen. Gallbladder, where is this? Well, it's upper abdomen, but it's actually upper right quadrant abdomen. Liver as well, it's located right there with the gallbladder. And then spleen is upper left of your abdomen. If it's bleeding, it's going to be everywhere in your whole abdomen that's hurting. But specifically, if you have a splenic infarct, it's going to be upper left abdominal pain. And that is because it's associated with the dermatomes. Things that are in midgut, that's going to be right around your umbilicus, so T10 and T11. Remember, ovaries and testicles also have developed in this area, so they're things that have actually descended into the pelvis or descended into the scrotum that also can refer to this area. But these are the other ones as far as GI tract that can cause pain in this area around the umbilicus. And really, for patients that have these sorts of things, they're really going to be like, oh, it's either right around the umbilicus or it's kind of diffuse all over the middle portion of the abdomen. And again, those are your T10 and T11. And so just think of the classic presentation of someone with appendicitis. And you should be able to know this by now. Someone that comes in with appendicitis, the first thing they say is, I have abdominal pain around my umbilicus, T10, cough, cough. And then it migrates to my lower right-hand quadrant after a certain amount of time. If you see that in a vignette, like pretty much you should be thinking at this point in year one, that is appendicitis. Don't even think of it anything else. Appendicitis is pretty much, that's what the vignette will start off with. Abdominal pain around the umbilicus that migrated to the lower right quadrant. Bam! Appendicitis, period, the end. Other things that can do this, however, cause that specific pain are ectopic pregnancy. So if it's a young female, think of that. But appendicitis is kind of the classic one. And they'll be like a kid or something, 12-year-old kid or something. So that's definitely possible. But all these other guys are going to be referring pain to this area. And then hind gut, this is all L2, L1, L2. So that's going to be things down in your leg. So for example, someone that has diverticulitis. So diverticulitis is pretty much an outpouching. So if I have the colon wall, I have an outpouching, a diverticulum. This is someone that has been eating lots of fried bread and fried foods and all those sorts of things that cause lots of constipation. Someone that's not eating their daily fiber, so an old man, for example, that likes burgers and meat and bread and fried chicken. Those sorts of things can cause lots of constipation. Constipation pushes out on this, and someone has diverticulosis. If this becomes inflamed, diverticulitis is what this is, just inflamed diverticula. At that point, this person's going to have pain. They'll have other symptoms like fever and stuff like that. But where's their pain going to be? Well, where is L1 and L2's dermatome? Well, L1 and L2 usually go down into the leg. Since the diverticula are going to be found in sigmoid colon and descending colon, that's over here, and this is going to be on the left side of the patient's body. So it's going to be towards the left lower quadrant and left leg or upper leg. And that's actually exactly where the referred pain is going to be for someone that has diverticulitis, because this is where diverticulitis occurs, is outpouching in these areas. And then obviously anything in the rectum and stuff like that, it's all going to be kind of referring down in those same areas we were just talking about. But remember, this is kind of the orientation of the GI tract. Keep it section foregut and then midgut and hindgut, and we'll be definitely coming across this so much that it'll kind of burn in your mind. Now, if we were to talk about blood supply, this is actually a great picture. I don't want to kind of go to the next slide because it actually shows the main branches of the aorta. So we have up in the heart, right? So we have our little heart. And off our heart, we have this arch of the aorta. Now, the arch of the aorta gives off the right brachiocephalic. It gives off your internal common carotid, and it gives off your left subclavian, and then continues down. There's perforating branches for the ribs and for the spinal cord and stuff like that. However, once it gets down into the abdomen, it gives off your renal arteries. And then it starts to give off these branches. And one of them is going to be your celiac trunk. Your celiac trunk, please remember, as your first section of your abdominal organ blood supply. And so that is going to be the thing for your foregut. So all the foregut structures we talked about, celiac trunk is your go-to. Midgut is then going to be the next artery, which is your superior mesenteric artery, which is written for some reason way at the top of this picture. But this is this guy right here. And so it's going to be supplying all the midgut structure. So all these ones from here down to here. And then lastly is going to be your inferior mesenteric, which is mentioned right down here. And that's going to be everything for your hindgut. So if I were to say, okay, this person has an infarction in the liver, where did the blood supply come off of the aorta from? Celiac trunk. If I say, oh, this person has an infarct in their appendix, where's the blood supply that comes from that? Well, that is going to be your superior mesenteric. And if I say, oh, this person has an infarct in their rectum, where is the blood supply for this? Well, that is going to be your hindgut blood supply, which is your inferior mesenteric. So keep it organized like that, and you won't miss any of these questions. Obviously, there are a couple locations where our blood supply between midgut and hindgut anastomose, and we're going to be talking about this artery here, and between the foregut and the midgut, and we're going to be talking about that artery as well. And that is where questions come from for blood supply, is what supplies each of the organs, ta-da, and those branch names. And then what's the anastamosis, what's the branch names in the midgut, what's the anastamosis, what's the branches in the hindgut. And that's it. That's all we can ask you in arterial supply are those simple questions just like that. Now, it is kind of annoying to learn the names, but most of them actually describe where they're going. So also keep that in mind. Okay, so let's talk about blood supply as far as the foregut, the midgut, and hindgut. So we just talked about the main branch, so our celiac trunk or superior and inferior mesenteric, but we're going to actually talk a little bit about what are the branches off of each of those, and then how are they associated with the venous drainage of these. So we talked about our celiac, and celiac gives off things for our liver, such as our hepatic. It gives off things for our stomach, such as the left gastric, which is then going to go up to the esophagus. And then it also gives off a nice tortuous vein or artery that goes behind the pancreas, and that is your splenic artery. And then there are smaller branches that come off of that, and we'll be showing you those in just a second. Then following that, we have our renal arteries. And then at the renal artery height, we have our superior mesenteric, and that gives off everything for our midgut we were just talking about, and then hindgut. And then, okay, that now gets to those organs, but those organs need to drain blood somehow. And so here comes one exception I'm going to emphasize to you, and please remember this all the way through term 5. You're going to impress your doctors, and guess what? You're going to get some nice questions on quizzes and tests in your 5th term, and you're going to continue on, take your step, and totally murder any anatomy questions that come along because of this particular detail. So here we have our liver, and we know that there are 2 things that get blood to it from draining in different areas. So if you have your arm that has venous blood draining from it, so say from your left thumb is going to drain through all the venous supply of your arm. It's going to make it up to your shoulder, and then it's going to dump into your heart, right? So the heart is one place that gets venous blood back to it, especially the right side of the heart, as I drew here. But then one other thing before the heart actually that needs to filter some blood is called your liver, as we know this. This is the liver right here that I circled here. And so this is kind of a detour before the abdominal blood supply makes it to the heart. Why? Is because people ingest toxins, people take drugs, and all this stuff that goes down in your GI tract. All the nutrients, the glucose, the fats, everything you learned in biochemistry when we're talking about digestion and talking about chylomicrons, for example, all those things get absorbed and are brought into the portal venous system. And that's what this blue vein up here is called. This is the portal vein. And the portal vein comes into the liver. The liver filters and metabolizes all sorts of stuff. It makes nice VLDL molecules, VLDL, from the chylomicrons that came from the gut here, chylomicrons, if we're talking about fat, for example. Okay, so all these nutrients get absorbed from our gut, that we eat all this wonderful, delicious food, gets absorbed, has to be filtered first through the liver, and then it can go back through the hepatic vein into the heart, via the inferior vena cava, and then continue out in the body to give the body all the nutrients that we absorb in our gut. That's kind of how this flows. And so for the portal vein, which is this one right here, we have things that contribute to it. And it's going to be going along with our arterial supply that we talked about earlier. So anything that comes from our foregut, our midgut, or hindgut arterial supply is going to then, in venous drainage, be coming back to the portal vein. Okay, those are the only things. So did I say that the celiac or the superior mesenteric or the inferior mesenteric, did any of those things supply my kidneys? No is the answer. Why? Because the renal arteries were their own thing. These are not one of these three things. And so therefore, their venous drainage will not go into the portal system over here. Only things from celiac, only things from superior and inferior mesenteric are going to be coming back venous drainage. And this is actually exactly what they're called. Superior mesenteric vein is going to be supplying everything that the superior mesenteric artery supplied, midgut. Inferior mesenteric vein is going to be draining everything from the inferior mesenteric artery was supplying. And so that is hindgut. And then the splenic artery went to the spleen, and splenic vein comes back from the spleen. And those are all going to be connecting into the portal vein. Now, one thing I want to kind of point out here is that this diagram does show one thing very particular that actually gets tested, and I want to actually emphasize this only. So let me go ahead and clear off all the ink from here, and I will circle that one thing. Now, if you want to get extra points, get a nice point on your tests, please remember this right here. And you might be going, Clark, you're ridiculous. What the heck are you talking about? So remember, in anatomy, they love pointing out weird things. Remember, in our pelvic section and our reproductive section, we talked about the ovarian artery or ovarian vein and the left testicular vein coming back and plugging into renal vein before it went into the IVC. We talked about that one exception. This is an exception that you need to remember. Well, one other exception for venous drainage is that inferior mesenteric does not plug directly into portal vein. It plugs into the splenic vein first, and then the splenic vein goes into the portal vein. So just this little green thing going to the purple thing actually is super significant as far as questions go. To be honest, like, I could care less, but again, you're in anatomy class, so definitely remember that that is one exception for venous drainage. That's just super weird, okay? Yeah, pretty much just please remember that. All right. So let's talk about some more details further beyond just celiac trunk, hepatic, splenic, and gastric. Okay, so let's talk about a little bit of these. Okay, this is actually very, very important to know these branches. Foregut is actually the most important out of all the sections. Hindgut has a lot of clinical sections that they talk about, and so we'll get to each of those. So off of the aorta, we have our first area. This is called our celiac trunk right here. From our celiac trunk, we have three main branches. We already emphasized those: our hepatic, our common hepatic, our splenic, and then our gastric artery, our common gastric. And from this, let's do the gastric first. The gastric, like I said, goes upward and supplies the lower portion of the esophagus. So if someone has an infarction to the esophagus, you're going to say, where did that come from? Gastric, celiac. Okay, that's where that came from. And we'll talk about venous drainage from this as well. And then from that, it also branches off and gives the lesser curvature called your left gastric artery. Your right gastric comes off of over here, off of your proper hepatic artery. So these kind of, you can see the arrows pointing towards each other. But that's okay. Just knowing that your right and left gastric supply the lesser curvature, that's what's important there. So if this person has an ulceration of the stomach, say they have H. pylori, then that ulcer is going to break through and they're going to have some acid that drops down on the lesser curvature. What artery is damaged? It's going to be your right or left gastric artery. They will not have you pick in between both of those. It's going to be one of the other. But if you have something on the lateral wall of the stomach, such as over here, an ulceration, then you're going to injure this artery. And that artery actually comes off of splenic. So here's my splenic. It should be very tortuous. They always describe it as tortuous. If you have anything that says, oh, look, we have a tortuous artery, that's splenic, okay? The end. Like, nowhere else do you have actually tortuous arteries, and except for the endometrium during proliferative phase. But anyways, so this is our tortuous splenic artery, and that will give off this left gastroepiploic, and then off of your your gastroduodenal, you're going to have off your other piece of the right gastroepiploic that just does the greater curvature of the stomach, which is the big one here. But just remember, gastroepiploic is the one that's damaged if you have ulceration of the lateral wall. If you have the lesser curvature damage, then you're going to have the lesser curvature arteries that could be damaged, and that's your gastrics. And ta-da, you're done with stomach. For the most part, actually. There's one other thing. Now, I do want to mention this one right here, is from your splenic, you have this little tiny artery branches. And this supplies the fundus of your stomach. And when someone has hypoperfusion, so say someone has a massive myocardial infarction, a massive heart attack, and now their heart is not pumping, they're getting low cardiac output, decreased cardiac output. Therefore, what happens? We decrease perfusion to tissues, such as the kidneys are going to definitely feel it. That's going to be a problem in the kidneys. You can cause kidney failure with that. But also areas of like watersheds. And so I'm not sure if you're familiar with this concept yet, but watersheds are pretty much where I have a section of tissue, which is this box, that is supplied from one artery that's coming in from one side and one artery of the other side, and they kind of like cross over and share this area of blood supply. However, if I take out one of these, then we're only going to be supplying half. Now the tissue was used to 100% perfusion, but now we just cut it to 50% perfusion. So is that going to be happy? No, it's not. It's going to die, and it's going to be very bad. So what's weird is that if I have a tissue that is very like almost the end of the arteries that come off. Here's the very tip of very far arteries, celiac trunk, splenic artery. Spleen takes a lot of artery, and then we have this little tiny artery that comes out here. This is an area that has hyperperfusion injuries due to someone that has a heart attack or decreased perfusion. That's your short gastric artery. This is super important clinically for your foregut stuff. Okay, so that's your spleen, that is your stomach, and your esophagus. Now, lastly, are a couple other things. You have your common hepatic, then your proper hepatic, and your left and right hepatic, and whatever. You also give off your cystic, which goes to your gallbladder. Cool. We'll be coming back to that in a little bit, but that's pretty much the extent of what's important there. Other things are off of the common hepatic. We also have this gastroduodenal. So you can imagine, where does this go? Well, it goes the gastroduodenal junction. So this is supplying this area here. It's also supplying the duodenum and also gives off supply, like we just were saying, the gastroepiploic. So that's the gastro part of this. And then we also have one small branch. And this is actually, surprisingly, the small branches are always the most important ones. It gives off these ones, anterior and posterior superior pancreatico-duodenal arteries, and this is our anastamosis point. So always when you get to areas of blood supply, anastamosis points are one of the actual most important things and highly tested. So not only is it an anastamosis point between the foregut and the midgut, you'd have to ask yourself, what is it around? Well, it describes it, posterior and superior pancreatico, so around the pancreas. The duodenum is the other portion of this. So pancreatico-duodenal artery supply. And superior mesenteric, which is our big supply that's going to come off of here, which we will be talking about in just a little bit. This supplies your midgut, remember? Well, this gives off the bottom portion of this. So this is the superior portion come from foregut, and midgut's going to supply your inferior portions of these, and they will anastomose around the pancreas. Now you might be saying, cool, that's a nice anastomosis in case there's some random occlusion in this gastroduodenal artery or something. Cool, Clark, how else is that important? Well, how else it is important is this. Where do ulcers mostly occur in patients? Well, if someone has peptic ulcer disease, the ulcerations occur here in the duodenum, the first part of the duodenum. So when this ulcerates through, just look at where gravity is going to take that acid. That acid is going to drop right onto these arteries right here. So please remember, if you have ulceration of your duodenal bulb, which is the first section of the duodenum, that these arteries are going to be the ones that are damaged. That is almost a guaranteed question right there. You're going to see it in Gray's Anatomy review book. So please find that question, circle it, memorize the heck out of that, and you just got your free point on abdominal exam, okay? That is super, super important. Okay. So that pretty much covers your ulceration, blood supply that's damaged, and blood supply of your foregut. So now let's talk a little bit about midgut. I know it's a lot of details and you might have to watch this a couple times, so that's why I'm kind of talking fast, so you could not have to spend hours and hours and hours listening to Clark talking so much, and you can get to the end where there's wonderful jokes on the last slide. Okay, so with our midgut, again, we emphasize this is your superior mesenteric. That's the most important thing. So that's going to be this giant red thing right here. And superior mesenteric gives off branches that go to the associated areas. So what does superior mesenteric supply? Well, the midguts. That's the second part of the duodenum to the 2/3 mark of your transverse colon, or the splenic flexure is what that's called, which is right here. This guy. This is where it ends. Ta-da! And the spleen lies right here. So splenic flexure, the part that this flex is, okay? So we have our superior mesenteric, and it gives off our duodenal branches, which we were just talking about, our little ones that came up here to the pancreas. That's our inferior, right? So our inferior pancreatico-duodenal arteries that supplies our pancreas and our duodenum that come off of here. And then it's going to go to all our small intestines. So past duodenum, we have our jejunum, and that's going to be all our jejunal branches, and our ileum, which is going to be all our ileal branches, which are all found right here. And then at the end of the ileum, which is ileum ends right here, we have our ileocecal valve. This is a valve that comes like this, and that dumps poop into the large intestine. And you might ask, Clark, why do we have that valve? Well, this has lots of bacteria. This has no bacteria. And so that we can absorb lots of nutrients in the small intestines. The large intestines is just for absorbing water and spitting out poop and storing it so that we can be walking around with lots of poop in us. Bacteria, we don't want bacteria to come back into our ileum. And if you learned in histology in the gastrointestinal section, ileum has lots of Peyer's patches, which are inflammatory cells storing in aggregates, and this is our lymphoid tissue found in our terminal ileum. Why is that? Because we have lots of bacteria that come back in this area, and we want to make sure to fight and get rid of those and keep the small intestines a sterile environment so we can absorb nutrients. When you get to year 2, you'll learn about pathology and some testing. When you have someone that has like a GI stomach bug, the stomach flu is what they call it. And that's why people they lose a lot of weight, not only due to diarrhea and vomiting, but actually because they're not absorbing any nutrients that they are trying to intake, because it's not even being absorbed, even in small amounts. But that's for another topic. So we get to the end of the small intestines, and we have the cecum, which is the end of the small intestines. We have this little appendix down here, the ileum. And so this is going to be your ileocolic artery that comes down to this corner here, and that's going to be supplying all those areas. And then we have our ascending colon as the poop goes up this way. And since it's on the right side of the body, normally in patients, it's going to be your right colic artery. And then as we get to the middle, so we have ascending, we have descending, and then we have transverse. The transverse is also called the middle colon. What does our blood supply to that? Well, that's going to be the middle colic. Ta-da! Woohoo! And once we get to this 2/3 area, 2/3, we have now finished midgut. So now our blood supply after this point is all going to come from hindgut. Now, hindgut is going to be starting at the 2/3 mark, or the last third of the transverse colon. I know they like to mess around with your fractions and numbers and get you all confused. But before we talk about this, I want to highlight this, and I'll highlight it again in our anastomosis slide. But our marginal artery is the one that connects our midgut to our hindgut. Remember, our descending colon is hindgut. What is this artery? Well, this is coming from hindgut. So remember that our marginal artery is the name of the artery that actually hooks those two together. So if someone has, and this is wink, wink, wink again to another question on your exam. Someone comes in, this 45-year-old man with high cholesterol. He's been smoking since he was 4 years old. He also drinks a lot of alcohol and eats burgers, all meals, every day. And he's horribly obese, okay? Lots of cardiovascular risk. And he has a large occlusion of his superior mesenteric artery, occluding everything of your midgut. How is the midgut then going to get blood supply to the transverse colon? Well, you'd say, okay, that's probably not coming from my inferior pancreatico-duodenal, those miniature arteries coming from foregut. It's actually coming from hindgut. What is the artery that hooks hind and mid together? Marginal artery. You just got a free test point question. Okay, that's exactly how they do those. They give you a nice little clinical vignette, puts the person at risk of having clots, and then they say, oh, here's the clot. How's the anastomosis? What's the artery? Bam, marginal at the end. You now got free point. You can move on to the next question. Okay, that is midgut. So now lastly is hindgut. What was the main blood supply from that? You're right, inferior mesenteric artery. So your inferior mesenteric artery is going to be everything from that 2/3 mark again. Continue down, and now that we're on the left side of the body, can you guess what the name of that artery is going to be called? That's right, left colic artery. And then what ends up happening is we start branching off and we get to the sigmoid area. Why do we call it sigmoid? Because it actually makes a giant S right here. And that's going to be your sigmoid artery branches. And then you're going to have this branch that comes down here, and this is called your superior rectal artery. Superior rectal artery will supply all of the rectum pretty much. You do have some blood supply that comes up from your iliac arteries that will anastomose in this area as well, and they kind of cross over in this area. And remember what we said when we have crossover between arteries? We have watershed areas. So if someone has an infarct of their superior mesenteric, like I was just talking about on the last slide, where's our watershed area? It's going to be at the 2/3 mark. Yes, the marginal will help to connect us, but we're still going to have less than 100% blood supply to this 2/3 mark, and so this is going to get a little bit dead and infarct. There's going to be a connection between our inferior mesenteric supplying here and our iliac arteries supplying here. And so we're going to have a wedge at this recto-sigmoid junction. And that's another place that is watershed. Please remember that. You're going to get a question right on your UWorld come term 5 when you get there, and you'll feel wonderful about yourself because you remembered about these watershed areas in these two places. As far as your inferior mesenteric, remember 2/3 that all the way down to rectum, and that's pretty much it. Venous drainage for all of these things are going to be associated with each of the arterial supplies to the regions. Okay. So lastly, I want to just quickly point out, I already talked about these. I just have a nice slide section for them so you can see the pictures. For your foregut to midgut, it's your pancreatico-duodenal arteries. Remember, ulceration of this area is going to land on top of these arteries. Also remember that they're damaged in that way as well. Midgut and hindgut, remember that's your marginal, and that's going to be occurring pretty much at this point right here, okay? That is connecting this yellow and this green together. That's your marginal artery, and that's mid to hindgut. Okay, so now that we've talked about a lot of blood supply and you're like, oh my gosh, I am just blooded out, let's talk about some of the autonomics. Now, one thing that people really hate about the autonomics is because the sensory nerves kind of come along next to the autonomics in our abdomen. And people like to mess up where sensory and referred pain and all these things, because now that you're in anatomy, they're asking you about the splanchnic nerves. They're asking you about visceral afferents and somatic afferents and efferents and all these things, and you're getting all these terms messed up, and you're like, I don't know what's happening. Are they going with sympathetics? I don't know. Are they going with parasympathetics? We just did pelvis, and some of the things below the pelvic pain line were with parasympathetics. It's tons of crazy. Please help me, Clark. All right, I got you. Okay, so autonomics are split into sympathetics and parasympathetics. Now you just have to think of this as you in a scenario. You go outside. It's 10 p.m. at night. It's dark. You're in a dark alley and you hear a roar of a tiger behind you and a guy with a mask that wants to mug you. Okay? What do? Well, you automatically are going to jump into that fight or flight, and you're going to be jumping up on your sympathetic nerves. Now, your sympathetic nerves do lots of things. First, they're going to dilate your eyes. Why? So you're going to absorb as much light in your eye. You can catch all the detail of the area at this dark alley, so you can make sure to make the correct parkour corrections as you're jumping over the building to run away from this tiger and this guy who wants to mug you. That's one thing. The other thing is heart rate and blood pressure. So you're going to be cranking out, increasing cardiac output. So that's all the heart things are going to be occurring. The other things are sympathetics go to your sweat glands, and it's going to make you sweat a little bit more. Why? You might be thinking, how that's counterintuitive for me trying to grab onto this building, but actually sweat will allow you to have a stronger grasp on certain things. We're made to be climbing up all these different things like stairs, like elliptical machines or the stair climber things at the gyms. That's what we have our sweaty hands for. Either that or climbing rope like you're back in 3rd grade or something. Okay, so sympathetics are going to be jumping on that, but how do all these areas, including your muscles, well, your muscle is going to be increasing its blood supply so you can be running away from these things. But how come all these areas are getting extra blood? Where is it coming from? Well, sympathetics, as far as the GI tract, are going to be going via the splanchnic nerves, and that's what these are: the greater splanchnic, the lumbar colonic splanchnic nerves, and your hypogastric, also known as your least splanchnic, and this is also your lesser and least splanchnic nerves. And what they do is actually constrict all the blood to these areas. So we take the blood away from all the abdominal organs. Why? Well, this person's not wanting to digest a hamburger. They're wanting to run away from a tiger. Okay, so who cares about the hamburger? We can digest that later. So we're going to cause vasoconstriction. And that's actually what our alpha-1 receptors do from our sympathetics that are going to all these areas to cause that vasoconstriction. And these go, and we'll talk about these nerves as far as where the roots come specifically, but remember how they come off the spinal cord. So here's the spinal cord, and then we have our dorsal root ganglion, which is this bulby thing right here. And then we also have our ventral horn, our ventral root, and then those will make our spinal nerve. Okay. All right. I know, wonderful drawing. But here's our spinal cord. From T1 to L2 or L3, we have our lateral horns found right here. And this is where sympathetics come from. And from our lateral horns, they're going to come down through our ventral horns. They're going to go in our spinal nerves and then go out our white rami communicans to our sympathetic ganglion. Now that can go up and down the chain of the ganglion, which is signified by these guys right here, these little ball things. And then if it wants to go to the body, to the sweat glands, it's going to go back via gray rami communicans. If it wants to go also to your erector pili muscle, it's going to do that same route. Or if it wants to go to organs, it's going to instead of going outside via gray rami communicans, it's actually going to go inside via our splanchnic nerve. So here's our little nerve. I'm going to draw this in 3D. Here's our little splanchnic nerve, and this goes to our GI tract. We also have our cardiopulmonary, T1 to T4, and that's for our cardiopulmonary, hearts and lungs. So we can breathe more, get more oxygen in, pump our heart harder. That's what's happening here. But we also go via the splanchnics, greater, lumbar, and hypogastric to constrict our blood supply. And so that's what this nerve right here is actually happening. So that's our sympathetic side over here. Then we also have our parasympathetics, and these are way easier to remember because it's pretty much vagus for our foregut and midgut. And then our pelvic splanchnics are S2, 3, 4. And remember, these are parasympathetic fibers. Parasympathetic fibers are our P for P. And these are the ones that are going to be going to our hind gut structures. Now, please remember that our hind gut structures, Where's hindgut? After the 2/3 transverse colon. Okay, so 2/3 transverse colon, there's our hindgut. That's our pelvic splanchnic nerves. I know this is drawing like these little lines to the wrong part of the colon. Don't worry about it. Just remember from here down, this is going to be our hindgut. That is pretty much what our pelvic splanchnic nerves are going to do. What is the purpose of these? To do opposite of our sympathetic. So these are going to cause vasodilation in the organs, the stomach, the small intestines, the colon. That allows for more absorption and bringing in nutrients to the liver. That is then going to, by the portal system, and then go back to the heart and give our body all those nutrients. This is our rest and digest. So this is after you get away from the tiger, after you get away from the guy you're mugging, you're back home safe with a locked door and a gun in your pocket. Okay, that is when you are ready and to start digesting, and your parasympathetics are going to start to work. Okay, so this kind of is just a brief charted description of what we're talking about, and it also tells where our splanchnics come from. So T5 to T9, T10, 11. This is our lumbar and sacral. Actually, this is our S2 through 4. Sacral. Don't worry about these guys very much. And then least is going to be RT12. And these are the ones that really just kind of supply different areas within here. Okay, so that just refer to that chart. So as far as referred pain, we talked about this. Remember our foregut structures. They're going to be all located around the epigastrium. Our midgut structures and our ovaries/testicles in males are going to be located in our mid region, and then our colon and our sigmoid colon and our rectum and all those things of hindgut are going to be located in the lower portions, including the legs, right? L1, L2 here. If you have any questions about referred pain, please refer back to some of our other videos. We go into further detail for that. Okay, so above all else, we've now covered arterial, we've covered venous, we've covered anastamosis, and we've covered nerve supply. Let's talk, as far as autonomics, let's talk about our GI tract lymphatic drainage. Actually, one thing before I start this, actually, for our nerves, please remember, as far as our referred pain, our sympathetic fibers are going to be the ones that carry our afferent nerves, our sensory fibers from our organs back with them. So if you ever have a question that says, oh, this person has an infarct in their spleen, right? Remember foregut, foregut, they say, okay, well, this person's feeling a lot of abdominal pain in their epigastrium. Foregut, like I was saying before. What is the nerve fiber that's carrying the pain sensation? Well, that is going to be a visceral, afferent, traveling with sympathetics. And the specific one that you're talking about is going to be your greater splanchnic. Because remember, that's associated with your celiac ganglion. Okay? Okay. So always for abdomen, all of them are sympathetics. Parasympathetics carrying pain fibers, that's only really occurring in pelvis below the pelvic pain line where peritoneum is not touching. So things like the body of the uterus, the cervix and stuff like that. Okay. So please remember that. Okay. So GI tract lymphatic drainage. So please don't remember these particular details on this slide. I just wanted to emphasize, like I mentioned, abdomen is very organized. So please don't know, pancreatico-splenic lymph nodes. You will never, ever get a question on this. No. But you will get a question on this. Well, if you have a spleen that has an infection, or you have a liver, or a stomach, or a first part of the duodenum, or an esophagus, where is that going to drain? Well, where the blood supply came from. Celiac. Foregut is where the lymph nodes are. So if someone has cancer of their ileum, okay, very rare. Someone has cancer of the ileum, where is that going to go? Well, their ileum is supplied from midgut. Midgut supplied from superior mesenteric. So where is that going to go? That's going to be your superior mesenteric lymph nodes, okay? If someone has rectal cancer, now this is a very high yield question, and actually really what your question is going to specifically say, it's going to be, oh, they have rectal cancer. Where's the lymph nodes drainage? Well, rectum is going to be inferior mesenteric. So That's where the blood supply goes to the rectum, so therefore the lymph drainage is going to be the same, inferior mesenteric lymph nodes. Ta-da! The end. Okay, so now on to some of the more clinical aspects. We've now covered the basic anatomy. So you should be very comfortable with some of these things, where the organs are and whatever. Okay, so let's talk about some of these pouches between the organs and some of the clinical aspects of this. So there are some pouches you need to know, such as the pouch of Morrison, the subphrenic space, and the pouch of Douglas. Now, we talked about this one a lot in detail, and so I'm not going to actually include this here. So go back to my pelvis and perineum lecture, and you'll find all about the the pouch of Douglas, also called your rectouterine pouch. Okay, that's found in women. That's what fills up with fluid if this person is sitting upright. Okay. However, there are a couple that you should know. The pouch of Morrison, for example, is called your hepatorenal recess. So if I were to ask you, is that on the right or left? Please say that it's on the right, because the liver is on your right. And so the liver and right kidney is where your hepatorenal recess, or your pouch of Morrison. And this is going to be in between these. And so you can actually see this right here. And you might go, oh gosh, well, Clark, why is this relevant at all? Well, someone that has liver failure or liver cirrhosis, they might have ascites, so fluid can fill in there. But it's actually very important for someone that comes in trauma. Now, I just have done my trauma rotation, night trauma, this past week down in Stockton. You can imagine Stockton, California is very, very dangerous, and lots of things come in: gunshot wounds, stabbings, car accidents, all sorts of stuff come in. And so what do we do in the emergency room? Obviously, we stabilize them, get their vitals okay. While we're doing that, someone else is checking a FAST exam. And this is very important for visualizing the abdominal areas that fluid can collect if they're bleeding into their abdomen. So if someone gets stabbed in their abdomen, they're going to be bleeding in there. Let's make sure that they're bleeding. If someone gets in blunt trauma, they get in a car accident, something hits them in their belly, and they're like, I have abdominal pain. We need to find where that blood is collecting. When they're laying on their back, the fluid's going to come and pool down in this area. It's called the pouch of Morrison, or hepatorenal recess, on the right side of the body. And we can find it such as this right here. You can see this little bit of blood. This is the kidney. This is the liver right here. And then in between them should be a nice capsule white line, but I see fluid in this dark area right here. And that is someone that has a positive FAST exam. And this is something we need to get them up to the operating room to do some surgery to fix whatever is bleeding. Okay. Blood also can go over on the left side. So this was the hepatorenal recess on the right, because the liver's on the right. What's the organ on the left that's above the kidney? That's going to be your splenorenal recess. It doesn't have a name, it's just called the splenorenal recess. And we can also find a positive FAST exam on them as well, and it looks very similar to this. The spleen is a little bit darker than the liver, though, on ultrasound. And then we have our subphrenic space. Now, this is someone that most likely has a stab wound to the abdomen or some sort of bowel perforation that lets air slip in the abdominal cavity. You shouldn't have air in your abdominal cavity, but sometimes air can get in there, and we can see that. So when someone sits upright, the air actually floats up to the top, because remember, fluid follows gravity, air doesn't, it goes the opposite. So air is going to go up to the top, and it's going to go right under the diaphragm right here, and then it's going to separate the liver. And this is going to create what is known as your eyebrow sign, or crescent sign. You can see these eyebrows over here. Oh, sorry, I drew that line up too low. And so that's going to be your eyebrow or crescent sign. So here's the eyebrow and here's the eyes. Whoa. Okay, I mean, he's probably sad because he's got air in his belly. Okay, this is our subphrenic space, and that's someone that has bowel perforation. So please remember those eyebrow signs, and my wonderful drawing. Don't ever forget that, okay? All right. So some other anatomy that's also clinically relevant is remembering what is greater and lesser sacs. Actually, this comes up a lot on STEP. I think I had a couple questions that were referring to greater and lesser sacs, where fluid kind of goes, how I can assess different things like through the Epiploic Foramen and whatever. So how to remember what this is to remember spatially, like where this is in three-dimensional space. So when you go through the abdominal wall, you get into the abdomen, you get right into the peritoneum, and you're in this space. You see a bunch of fat in front of you, like right here. and you see some part of the colon, and you see the liver, and you're like, ew, there's sacky stuff here. It's gross, okay? You are now in the greater sac. And in the greater sac, you have this fat, which is right here. This is greater omentum. And you're in the greater sac, which is this whole space, red and yellow, okay? And then if you want to go into a very small area, you have to go through a little door. And this is through what is called the foramen of Winslow, or Epiploic Foramen. And now this is very particular, and we'll talk about this clinically, but once you go through here, now you're no longer in this giant space that's all connected, the yellow and red, but you're now in this blue area, kind of hidden, and it's kind of a sac in behind here. So this is the blue sac. You can see this right here. It's actually behind the stomach, through the epiploic foramen, under the liver, and under the gallbladder and the common bile ducts. You can actually slip in through this, and now you're in this kind of sac behind the stomach and above your pancreas and above your transverse colon. So here's your pancreas, is the back wall, and now you're in this kind of blue sacky area. Okay, this is called your lesser sac. So your greater one was the greater and bigger one that you come right into in the beginning, but then you can slip back into this little pouch, and that's called your lesser sac. This is also called your omental bursa, which is so dumb, but why they have to give everything like 50 names. But please remember, your lesser sac or omental bursa is this one in the back here, behind your stomach. Now, since we're talking about epiploic foramen, what is that and why is it important? So here it is. Here's the liver. Here's the stomach. Here's the gallbladder and the common bile duct. Hepatic duct comes down here. And there's this little hole. And now I slip back here, and now I'm in my lesser sac. Well, right here, we actually have important structures. We have our cystic duct. We have our hepatic artery. Where did that come from? Our common hepatic artery. And that came off of foregut celiac trunk. Okay? From that, we also have the blood supply to the gallbladder itself, which is our cystic artery. And so, and then lastly is a nice fat vein that goes up into the liver. So remember, we have artery, we have vein, and then we have duct. So AVD, or DAV or VAD, whatever you want to do with those letters. Okay, so we have a vein, which is our portal vein, our hepatic artery, and our duct, which is our common bile. Okay, so all of these three things, if we clamp them off, this is known as the Pringles maneuver. Now, this is similar to what you can do with your fingers trying to grab Pringles at the bottom of the chip little tube. And so you can actually use your fingers and you clamp off this area, and that's called the Pringle maneuver. Usually we use a metal clamp like they're showing here, but just imagine yourself grabbing Pringles with your two fingers at the bottom of a Pringle chip thing, and that's your Pringle maneuver, okay? That's an easy way to remember that. And that cuts off our portal triad or common bile duct, our hepatic proper artery, and our portal vein. This is very important clinically because sometimes some people get stabbed in the abdomen. All the time here in Stockton. So people get stabbed in the abdomen, they're bleeding out from, there's just blood everywhere. What's happening? All I see is blood. And then you're sucking it up and they're still bleeding or whatever. Well, you can assess, is it coming from my portal vein or is it coming from my hepatic artery? Well, how do you do that? Well, how about this? If you do the Pringle maneuver, it should stop bleeding. Period. The end. But if you do the Pringle maneuver and it's still bleeding, then it's one other vasculature which is running right here, a big giant thing coming and draining the whole lower body, your IVC. So this is huge points, like free point questions on your exam, okay? Someone gets stabbed in the abdomen, you do Pringle maneuver, or you reach into the triangle of Colo, which is this triangle here, and you squeeze off these structures, the portal triad, and yet they're still bleeding. What's damaged? IVC. You just got a free point on the exam question, okay? Remember that these structures are here. IVC is behind this. So if I were to reach my finger, I can feel the IVC behind these three structures. But if this person stops bleeding when I do my Pringle maneuver, then it was one of these things. Either the portal vein, the hepatic artery are the things that are going to be bleeding from there, okay? that's like free points. This is super, 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 super high yield. You're going to see this all the time on your surgery rotation. And so they want you to know this now. So please learn it. You're going to get some free points. All right. So now pancreas. We talked about some of the pancreatic things here. We talked about some of the arteries in the inferior and superior pancreatic duodenal arteries and the anastamosis around here. But I'm just going to talk about some of the things that can go wrong here. And so we have these portions that make up the pancreas. We have our incident process. And our incident process is this little thing at the bottom of here, which is this. This is our incident process. We have our head of the pancreas, and then we have our tail of the pancreas. These are the three sections of our pancreas. And what makes them is actually some of the embryological origins. We have a ventral pancreatic buds, and usually we just have one, and it usually goes a clockwise rotation around the gut and then sticks in and makes the incident and our head of our pancreas. And now we have our pancreas. That's what our ventral bud ends up doing. However, sometimes we get a bilobal, sometimes these divide and make two of them. So one goes this way and the other one goes this way, and we can wrap around this. And this is called annular pancreas. And so annular pancreas, the cause is bifid ventral bud fused with the dorsal bud, and it encircles and obstructs where this is originating. Remember what we said? First part of the duodenum comes down out of the stomach, and this is dividing between fore and midgut. And right here we have the opening, the sphincter of Oddi that comes from our common hepatic duct and ampulla of Vater, and then that becomes our second part of our duodenum. So right here, if this is where our pancreas is coming off around, it's going to encircle around this second part of the duodenum, okay? So that is our annular pancreas. That's just one embryological clinical thing. It's not that high yield, I guess. Okay. What you can see on x-rays, you can see a double bubble, and you have to do CAT scan to find specifically that the pancreas is the one that's causing this problem. Okay. So duodenum, we kind of talked about this, the first, second, third, and fourth parts. There are 4 parts. We talked about the first. That's foregut. Second, third, and fourth are from midgut. The second has that ampulla of Vater, which we just talked about, and sphincter of Oddi. The third is the horizontal portion, and the fourth is actually a little bit more important. So the fourth actually ascends and comes up. You can see this right here. And this is kind of important because this is where we kind of hold up our duodenum. We have this ligament that kind of attaches down here. You can see this in this picture right here. That comes and attach on the fourth part of the duodenum and keeps it all upright. Okay, this is called the ligament of Treitz, and this is the dividing point that we use in pathology to determine upper versus lower gastrointestinal bleeding. So if someone usually has bleeding past the ligament of Treitz or past the fourth part of the duodenum, it's usually going to be red blood per rectum. Sometimes, it'll be like a mix of black melena and red blood in their poop, but usually it's kind of our dividing between upper and lower GI bleed is at that point right there. Remember, we talked about anterior and posterior ulceration. If you have anterior and posterior ulceration of the duodenum, remember the artery we talked about, the posterior pancreatic duodenal, we talked about that. Yes, remember, or gastroduodenal, which gave off that artery. That's very important. And also, what's right behind there? Well, in order to get behind the duodenum, we have to be in the lesser sac. So if we were to say space that it's found in, it's going to be lesser sac. Artery that's damaged are those arteries there. Anterior, well, you're in the front. There's nothing in front of you. So you're going to be right into the peritoneal or greater sac cavity, and it's just going to be like gobbity peritonitis. Lots of problems. Very bad abdominal pain. Okay, so we went all the way from duodenum down to anus. So this is your pectinate line. This is pretty much the dividing between internal GI tract right here and external skin. And so this is called our pectinate line. And this is kind of a separation between sensory, a separation between venous drainage and arterial supply. So everything kind of separates at this dividing line, and as well as clinical pain with someone that has hemorrhoids, internal versus external. So please remember, like, all the different things that are associated above and below this section. So if we're above, we have GI tract blood supply. So where did that come from? That came from inferior mesenteric artery is going to supply here. Well, the lower part of this is going to be your iliacs. Iliacs are going to be supplying this portion down here. As well as, and the iliacs give off a blood supply called your inferior rectal. And that's mentioned in this chart up here, okay? Inferior rectal supplies below the pectinate line. Above the pectinate line is going to be your superior rectal from your inferior mesenteric. And these are all kind of circled here, inferior mesenteric, superior rectal. And then these are the inferior and middle rectal from there, okay? That's your artery. Venous, I mean, the same thing. Please remember that's the same thing. You just put vein instead of artery after the name, okay? And then what happens if someone has portal hypertension, which we'll be talking about in just a second. Portal hypertension is someone that, that has liver cirrhosis, for example, is someone that can have portal hypertension. And this is where usually what happens is I have this tissue that wants veins to be drainage. And if it's above the pectinate line, it wants to go via the portal system. Okay, and then I also have this tissue down here that wants to be draining via the caval. What is caval? Vena cava. Cava, okay? That's what that means. So vena cava. So iliacs, go to common iliacs, go to inferior vena cava. Portal, or inferior mesenteric, remember, goes into splenic vein, and then it goes into the portal system, okay? So this general area right here found in between is kind of fighting between where the blood wants to drain to. Does it want to go to the portal or does it want to go to the caval? It's kind of fighting. Well, what happens if I have a backup of blood to the portal system, and so now I kind of fill in and everything's actually now wanting to more shove towards the caval system, well, I'm going to create a venous bulge. And if this is on the inside above the pectinate lines, this is called an internal hemorrhoid. And internal hemorrhoids are not painful, okay? If instead the backup is more on the external portion where you can actually very physically see it when you look at their anal canal, this is actually called external hemorrhoids, and those are very painful. And you might be going, why, Clark? Why must it be this way? Well, why must it be this way is because this is actually way easier than having some weird thing about it, okay? So internal hemorrhoids, not painful. External are painful. Why? Because of sensory. Remember, our visceral afferents come down to everything in our GI tract. Visceral afferents, unless it's really bad pain like infarction or whatever, you're not going to really feel anything. So internal hemorrhoids, their sensory is visceral afferents. And since hemorrhoids are not severely painful in the first place, like they're not really triggering of nerve fibers, you're not going to feel any pain. But external hemorrhoids are a lot more painful because they are coming off of the inferior rectal, which comes off of pudendal. Back to our pelvic area. So pudendal nerve is a somatic sensory nerve. And you know, somatic sensory nerve, when was last time you got a paper cut? How bad did that hurt? Okay, a lot. Okay, stupid paper cuts, especially in the cracks of your fingers. Okay, that is somatic sensory. So somatic sensory is very sensitive, even to like little baby lesions. So any hemorrhoids, even swelling in an area that's done by somatic sensory, is going to be very painful, and that's why that is. And that's it. Okay. All right. So what is this portal hypertension, and what is this, and how do we fix it? Okay. Now, you want another free point on your test? Or maybe even 2 free points on your test? Listen to my slide right now, okay? So portal hypertension, like I was talking about, with someone that has like cirrhosis. There are a few other things. You'll learn that in PATH. That's year 2, not for you to worry about right now, okay? So cirrhosis, just think of this. We're having backup vein into the portal vein, backup of veins everywhere that's draining in the GI tract, the stomach, and all sorts of things, okay? Now, the problem with that, however, is that we have certain areas that have that fight. Like we were just talking about the rectum, where we had that fight of where the venous drainage wanted to go to. Did it want to go up to your inferior or your superior rectal, or did it want to go to your inferior rectal? Right, this inferior mesenteric, or the actual, like, the pudendal arterial or venous drainage supply? Did it want to go over your portal versus your caval? Okay, well, there's multiple areas that have this matching, and these are called portocaval anastomosis points. Okay, the ones you need to know are here. We just talked about on the last slide. Those are hemorrhoids. Okay, those are hemorrhoids occur here. Now you already know that. Ta-da, we don't need to explain this one. Other ones that occur that are less likely to be tested are occurring at the retroperitoneal veins. Don't worry about these ones, okay? The other ones that you do need to know and are really going to show up and highly testable are these last two, okay? One is going to be very visible the second you lift up someone's shirt and you look at their belly. And this is called caput medusae. Caput medusae. Medusae. Okay, so caput medusae is an anastomosis point right around your umbilicus. And it's really kind of gross. If you don't believe me, just look at a picture. You'll never forget that picture ever. It's very tortuous veins. It's like snaking coming around the umbilicus like this. And that is your caput medusae. What causes this is a portocaval anastomosis. And what is the anastomosis? Well, one is your paraumbilical vein. And your paraumbilical vein is something that comes off of out of your hepatic arteries. Well, how do you realize what? Where did this come from? Well, remember in development and embryology and our neonatal in the womb blood supply. Well, the blood supply came through the umbilicus, and it came through the umbilicus, and it went through a nice ligament that comes right through here. This is called your ligamentum teres. Now, this is our paraumbilical vein is something that the blood supply came into your umbilicus, and then it went into the liver, bypassed the liver to go to the hepatic vein, and that went up to your heart. So remember, this is pretty much the blood supply, which is your ductus venosus. Remember, we looked ductus arteriosus, that's found in the heart, or at the heart, between the pulmonary and pulmonary vein, or pulmonary artery and your aorta. The ductus venosus is this guy right here. He went right through here. This kind of cut across over to hepatic artery to bypass the liver in neonates or in babies. Okay, so that is actually what your paraumbilical vein is, and so that's your portal side, your portal side. Your caval side is superior and inferior epigastrix. Where did that come from? Well, your superior epigastrix, please check out my thorax and my thorax videos. I talk about all that blood supply to the anterior chest, as well as our inguinal regions. We talked about our inferior epigastrix. Ta-da! Remember these guys? These are important to make our Hesselbach's triangle for your indirect and direct hernias. That's these guys right here. So these come from top, they come from bottom on the surface of the skin to supply the muscle and the skin of your abdominal wall. And then from inside the abdomen is going to be your paraumbilical vein. That's our anastomosis point. And when our paraumbilical vein gets dilated and full due to portal hypertension, you're going to see that caput medusae. And that's one place. The other place is going to be at our esophagus. So our esophagus, from above, the upper part of the esophagus. Remember how at the beginning of this video I mentioned that our gastric gives off our lower part of the esophagus, arterial supply. Well, it also drains the lower part. Well, the azygous vein actually drains the upper part of the esophagus. So here's another fighting area between our portal and caval. So our esophageal vein is our azygous venous drainage side, where our left gastric vein is the one that is our portal side, our portal vein. Okay, so please remember that this is very important to know what kind of vein goes with portal and what vein goes with caval. And it's very easy. We've been spending this whole time talking about fore, mid, and hind gut and the main arterial supply. So if you know the organs, that's it for portal system. If I say small intestines, that's portal system. If I say liver, that's portal system. If I say spleen, that's portal system. All these organs of the GI tract that we've been talking about, portal system. Everything else, your kidneys, your ureters, your abdominal wall, your brain, all those other things go via the caval system, your inferior and superior vena cava system. They go directly to the heart. They bypass the liver. So if I were to say this person has hemorrhoids, what veins could I then relieve pressure? So now this is where the questions come. First, you have to remember that these are the areas that you will find these anastomosis points, but that's it. That's not enough. That's undergrad anatomy. What you do need to know is, how do you fix it? Well, first, here's our meeting point right here. And we had venous drainage in our portal system. We had venous drainage in our caval system. And now let's say our portal system, because of portal hypertension, is very, very engorged. And it does not want to go up to the liver. It's very engorged. The liver is not functioning properly. Well, how do I fix this? This is low pressure. This is high pressure. So what can I do? Well, I can actually make a shunt in between this. Just take a little bit of artery from the arm and connect the portal to the venous or to the caval system. And now some of that blood is going to go over onto this side and kind of even it out a bit. Okay, so that is what our portal caval shunt is going to do. So how do I do this? Here's a question. Okay, I have a 35-year-old man who's been drinking since he was 4-year-old. He has cirrhosis of the liver, and I see him having esophageal varices. Now I want to relieve the pressure from our portal system, and I want to put in shunt. Which two veins can I anastomose together in order to relieve this pressure? All you have to do is find the answer choice that has one portal and one caval artery. That's all you need to do. You find one portal, which is any of the organs and any things we've been talking about so far in these videos, pretty much. Any of the venous drains names coming from the liver, coming from anywhere, that are in our GI tract, from lower esophagus all the way down to our rectum. All those things are going to be a portal. So you pick one of those, and then you find anything else that is not portal. So kidneys, or brachial, or something out in the caval system that doesn't need to go through the liver and is not part of the GI tract. That is going to be the second thing you choose, and you now have your answer, and you just got a free point. Okay, that is how you answer these questions. Do not forget it. This is very important. Okay, so last couple of things. This is going to be the finish of our GI tract video. Next, I'm going to simply do additional abdominal organs, such as our kidneys and their development. So check out that very short video that's going to be following this. I just wanted to keep everything GI tract related for this video. So some of the congenital things, obviously embryology, sort of important, but it's nice because it's almost rote memorization in a lot of cases. So things that you might see are in questions are like Meckel's diverticulum. And remember, this is very important to remember the rule of twos, and that's why I have a giant 2 here. And this is a remnant of the omphalomesenteric duct, also called the vitelline duct or yolk sac, is how they describe this. It's something that is 2 inches long. It has 2 types of tissue, such as stomach and pancreatic tissue found within it. So it might be making insulin, and it might be making gastrin, and it might be making gastric acid. So you can have ulcers in our lower GI tract, like our colon, which is super weird. Why are you having peptic ulcers in our colon? Okay, so 2 inches long. It's 2 types of tissues. It's 2 feet from our ileocecal junction. So the ileum and the cecum, start of the large intestines. It's in 2% of males, and it's usually diagnosed at 2 years old. So all these different 2 things. And remember, males, okay? Males, boys for this guy, okay? Next, we have Hirschsprung's disease. This is failure of neural crest cells migration. One special thing I wish I learned in anatomy was that we have our rectum, or like our large intestines, okay? Large intestines, a horrible drawing of our large intestine. The large intestine comes down sigmoid, then it comes to rectum, okay? Okay, so this is our large intestine. One thing that you should know about GI tract, Hirschsprung's, and neural crest migration is neural crest cells come in this way and they migrate down this direction. Okay, that is normal migration. Now, if you have a problem with migration, what is the most likely affected areas of Hirschsprung's disease? What's the place that pretty much every single person with Hirschsprung's is going to not have neural crest cells and no motility? Well, it's going to be the furthest place they have to migrate. They are weak baby neural crest cells when they fail to migrate. They only migrate a little bit of the way. So where's the problem? Always going to be rectum. If I stick my finger in someone that has Hirschsprung's and I trigger this, it's gonna dilate all this area, and all the poop that got stored up here is gonna shoot out. And this is like projectile pooping. This is called squirt sign, which is really gross. If you don't believe me, look it up, squirt sign. That's something in Hirschsprung's if you do a digital rectal exam in someone with that. But remember, the furthest part, the end of the rectum, is the part that's always affected because they migrate down towards that area. Other things are more like sigmoid and descending colon. Those are the areas that are going to be greatly affected by Hirschsprung. And then if it becomes toxic, it's called toxic megacolon, and ta-da. Gastroschisis, so this is a median plane. This is someone that has problem with lateral fold, so this is very early embryology. Remember, if I do a cross section through the belly of this person, and this is anterior, this is posterior, we have these lateral folds, and then we make our spinal cord right back here, and we have our lateral folds, almost like spinal cord back here. It's almost like I have a person right here. Here's their eyes, and here's their little smile, and here's their arms. And so in order to kind of close off this circle, they have to do this lateral fold. Well, if this doesn't occur, then this person's beer belly is going to stick out, and that's including bowel. And this is what happens with gastroschisis, is when bowel kind of sticks out in the median plane because of lateral folds failing. You have just gut hanging out. Problem with this, increased risk of infection, and the person can become hypothermic, or the baby will be hypothermic very, very quickly. So you got to keep them warm, fix it in surgery right away. Next is hypertrophic pyloric stenosis. This is something like projectile vomiting. Please YouTube what projectile vomiting is. You'll never forget it. There's a couple cute babies that have this, and they show it kind of spray out across the room. Please just watch it. It's like a 2-minute video. You'll find a few on there, and you'll be stuck forever. You never even have to even think about this anymore. But projectile vomiting is something that happens in little boys specifically, and it's usually about a month or two into their life that this occurs, and it pretty much doesn't allow gastric contents or stomach contents to be pushed into the duodenum, and it just shoots back out through the esophagus and through the mouth and sprays across the room or into their mother's face. Okay, so that's your projectile vomiting, and there's no bile because we didn't get into the duodenum to get the bile at the second part of the duodenum to then come back and vomit. So we actually just stopped it right here, so it just comes right back from this part. Duodenal stenosis versus duodenal atresia. It's just incomplete or failure to recanalize. And pretty much like the duodenal stenosis, there's still bile stain. There's still bile stain in here. Things that you'll see in both of these guys really is a double bubble sign. And then there will be an air fluid level. When you see those two put together, you're probably most likely talking about this, or something that is completely encircling the duodenum at this area. Pancreas slide that we just talked about a few minutes ago, and that's your annular pancreas can do the same kind of finding as well on x-ray. Double bubble. You can Google that as well. All right, last part, okay? I know these are really annoying, but these ones are actually the less likely to be tested. So if you have agenesis, of the anal canal, means it doesn't form, then we never made the division in the first place. And in our renal picture, I'll show you what that is a little bit. I'll mention that as we're talking about GI development, but that is incomplete separation of cloaca and urorectal septum. Rectal atresia, we didn't recanalize. Anything that has atresia, always remember it doesn't recanalize. Anorectal agenesis, and that's incorrect partitioning. And anal stenosis. So this is how you can do this is here's the canal, and what we need to do is, so this is going to be both your urinary tract, urine, and your poop tract. Okay, poop. So what we need to do is we need to have some tissue that comes down and divides them in here. And so we have this tissue that can divide them. Well, what happens is normally we'd have a nice opening of the urethra, you have a nice opening of the poop, and both would come out nicely. However, if this dividing tissue decides to go a little bit extra posterior instead, or also posterior is also dorsal, is another way of this, then you can see that the poop canal is now quite a bit smaller, and so we would call that stenosis. Ta-da! Okay, so imperforate anus as well. So this is something just anal membrane did not perforate, and we can just pop it, and yay, poop comes out. Okay, vitelline fistula. One other thing, so we talked about our Meckel's diverticulum. So we have our small intestine, right, 2 feet from our ileocecal valve here. We have our diverticulum here. And now from our diverticulum, if this diverticulum actually connects to the abdominal wall right here, we can actually have poop coming straight out into our belly button pretty much. And so when this person has poop coming out of their belly button, this is a persistent vitelline duct, and it's connected to that umbilicus, okay? And this is a vitelline fistula. Remember, fistula is a connection, abnormal connection between two epithelial types. And then lastly, our sigmoid volvulus. So this is obstruction of the colon, and you cannot pass the feces. This can occur actually in small bowels as well, but sigmoid volvulus, don't worry about it too much, but it just pretty much remember that anything that causes volvulus can cause obstruction. All right, so that completes our abdominal video. Don't forget to subscribe, and if you want the PowerPoints for our abdominal videos, check out our Facebook page, CK Med Plus, and you can download those now. However, also if you want to continue and read up or watch the remaining video that I have from other abdominal organs found within the abdominal cavity, such as our kidneys and other things, please check that out. It's going to be a very short video. All right, happy studying.